Are you a healthcare professional working with breastfeeding infants? Wish you knew more about assessing and treating tongue ties? Earn continuing education credits and transform your practice with the Professional's Guide to Tongue Tie in the Breastfeeding Infant. It's perfect for any practitioner who works with infants and their mothers, especially those working through feeding challenges. Learn to identify who needs treatment, build a qualified care team, and provide holistic care options. Discover the ins and outs of frenotomy, including procedure preparation and best aftercare practices. By the end, you'll be confidently supporting breastfeeding families armed with the latest protocols and be part of an interdisciplinary community of experts just like you. Tongue ties are nothing new, but the right way to assess and treat them is. Ready to make a real difference? Join now and become a tongue tie expert. Sign up today at tonguetieexperts.net/professional and become the evidence-based resource that your community needs. To show my gratitude, I'm offering you a special discount as a podcast listener. Use code PODCAST40 to save 40% off today. You're listening to the Tongue Tie Experts podcast, a weekly program providing information and support for those families impacted by tongue and lip tie and the professionals caring for them. I'm Lisa Paladino, a midwife and a lactation consultant with over 30 years of experience. If you are a parent looking for answers or a professional who is curious to learn more than what you learned in school on this topic, welcome. This podcast is for you. A gentle disclaimer. Please do not consider anything discussed on this podcast by myself or any guest of the podcast to be medical advice. The information is provided for educational purposes only and does not take the place of your own medical or lactation provider. Thank you. Welcome, everyone, back to the Tongue Tie Experts podcast. I'm so happy to be putting out new episodes again, and I promised you interesting guests, and today is no exception. I have Dr. Rishita Jaju, who is a board-certified pediatric dentist and the founder of Smile Wonders in Reston, Virginia. Dr. Raju completed her dental education at Harvard School of Dental Medicine in Boston and has specialty training in pediatric dentistry from Children's National Medical Center in Washington, D.C. She has achieved advanced laser proficiency certification from the Academy of Laser Dentistry and breastfeeding specialist certification, which I love. I love that you have that certification. And she has served on the Council of Clinical Affairs for the American Academy of Pediatric Dentistry and Examination Committee of the American Board of Pediatric Dentistry. Besides actively serving the profession as a private practitioner, expert laser dentistry provider, educator, speaker, and a published author, Dr. Rishita loves going home to her loving husband, active toddler, and 2 adorable Maltese doggies. And she is looking forward to traveling all over the world again and has visited every continent except Antarctica. Welcome, Dr. Rishita. Thank you for being here today.
Thank you so much for having me. I am definitely one of your, routine listeners.
Oh, I love that.
And I appreciate all the vast variety of the topics and everything. So I'm very honored to be one of the speakers invited to speak with you today.
Thank you. And before we jump into dentist stuff, 2 things hit me from your bio that hit home to me. Number 1, the dogs, because I have 2 very spoiled Shih Tzus who run my life. And 2, the travel, because I have dedicated 2023 is going to be the year that I make traveling a priority. So I love that you've been to so many places. And just off the bat, I mean, I know you're from India, right?
Yeah.
What's your favorite place to visit other than going back home to India?
My husband and I usually try to make it so that we're going somewhere for a reason, or we know something about it.
Mm-hmm.
So Europe is one of the go-to locations. I feel like if I had to move out of US, I'd probably want to move to Barcelona. Um,
Nice.
in Africa, of course, Cape Town
Mm-hmm.
is everybody's favorite. We had
Uh-huh.
a distant relative there, so we actually got like the locals
Oh,
view
that's
of
wonderful.
Cape Town when we visited.
Yeah.
But yeah, I think traveling is going to be a lot of people's goal
Yep.
this year.
Yep.
My
Absolutely.
goal is
But yeah.
stress free 23.
Yes, I love that. And the only thing, and it's funny that those two concepts, the dogs and the travel, were in the same bio, because that's what holds me back. I hate leaving my dogs. My
Yes.
oldest just turned 15, my oldest dog, and I worry, and I talk to her before I leave, and I go, please, Miley, please don't die while I'm gone. Hang in
Oh,
there, because she's elderly, she's suffering a little bit. Anyway,
oh.
now
Well, our dogs get to stay with our friends,
that's
and
nice.
we're lucky to have a very nice, experienced and close dog walker that,
Beautiful.
we leave her.
Mm-hmm. Yeah.
I mean, we approach her to take our dogs.
Mm-hmm.
And because the two that I have are siblings,
Oh, nice.
they actually, I say siblings, but yeah, they're litter mates.
Mm-hmm.
And I know that each of them have very different personalities, and in a way, they take care of each other.
Right. Yeah. As do mine. They're not siblings. They're 5 years apart, but they do take care of each other
Take care
for
of each other,
sure.
yeah.
Anyway, so enough about the dogs, enough about the travel. People are tuned into us to learn about and hear about tongue tie and tongue tie release. And the topic that I think is important to cover, and that you have expertise on, is the optimal timing. And is there optimal timing for release? And how the heck do we know what it is?
Oh, you jumped right into my
Yes,
favorite
I
topic. That's
did.
great. So, optimal timing of release, and it's also known as OTR in many conversations in like professional world, is super important. And I feel like that is actually a little minimized in our as our field. We are trying to create awareness
Mm-hmm.
and create the people's acceptance of the procedure. We have minimized optimal timing in a way, but I feel like it's time for us as a profession to pay a little bit more attention to it. There are many things that go in determining optimal timing. So many times babies may have visible attachment,
Mm-hmm.
and we all know the anterior tongue tie concept. Many times, babies may have a restricted function, but not
Mm-hmm.
necessarily a visible tie or a visible membrane,
Mm-hmm.
or it may not be coming all the way to the tip of the tongue.
Mm-hmm.
Many times, when it is coming to the tip of the tongue, and everybody in the hospitals mentioned it, and the pediatricians mentioned it, those are the ones that get the visible ties, are the ones that, sometimes get diagnosed and treated
Mm-hmm.
too early
Oh,
from
I
an
see that
optimal
too.
timing
Yeah.
perspective.
Mm-hmm.
Yeah. And if you treat it and expect that all of a sudden the muscles are going to know what to do and coordinate around, and all of a sudden it's going to become this great silver bullet answer, that's when you have actually missed the boat in getting the best outcomes.
Mm-hmm.
So that's where the optimal timing came about. And from a personal, professional experience, I felt like especially around COVID timeframe, from 2020 June through September-ish of 2021, 18% of my babies that I was treating were second releases.
Yeah.
Somebody
Wow.
else has already treated them,
Right. I you
quote
know,
unquote.
I find similarly in my office, I'll have people come to me because they've had tongue tie release and things aren't going well. And for those who
Yep.
don't know and haven't listened before, I'm a lactation consultant. So people are coming to me for breastfeeding problems, and I'll get on the intake form something like, my baby already had tongue tie release. That didn't help. And I don't know what's going on. And it's been done usually that quote unquote quick snip in the hospital, or the pediatrician noticed it and because it was so obvious and sent them to an ENT. Not that I'm belittling, nothing against ENTs, but in my experience in my area, the ENTs aren't doing the same type of procedure as the pediatric dentists are. So we have this misguided referral system that thinks they're taking care of something, but nobody has ever even looked at the function. Nobody's saying, how's it
Exactly.
going?
And so
Right?
that's where I call like a visual release
Yeah.
versus a functional release,
Right.
right?
Right. Yeah.
So when I have someone that has been treated already, or they have, come in with an expectation, the hardest patients are, I found you on Facebook.
Mm-hmm.
Because this is a family, or this is a baby and mommy that do not have the appropriate support
Mm-hmm.
and guidance to establish mom's health, baby's health, function, and then release. They are struggling on their own. They're doing their own research. They are trying to figure out the best resource, and they're coming to me, a surgeon, like
Right.
dentist,
Right.
for a procedure, and expecting that to be their answer versus
Mm-hmm.
really realizing that that is a part of the answer.
Right. And
So,
yeah. Can I stop you for a
collaborative.
minute? Because you
Yeah.
said something that like is my latest focus.
Mm,
Mom's health. Meaning, and that means emotional, mental, and physical health. Because in this field of tongue tie, there are so many providers who are treating babies who don't have it in their scope to assess the mother.
right.
And this is not just an infant problem,
Yes.
right? And how does a family handle what this procedure is, and what, not, as we've said before we came on, it's not that it's such a big procedure, but it's still a procedure. And anytime
Procedure.
you
Yep.
hand your child over to someone and say, do this to my baby, it's
Yep.
traumatic for the family. And then sometimes, the pre-work that has to be done, the follow-up that has to be done, what the evening is like. We have to make sure part of the optimal timing is making sure the health of that mother, the health of that family
Yes,
is
absolutely.
considered, right?
Yeah. And I have parents that, and the thing is, one of the reasons I pay a lot of attention to mom's mental state, because this is a mommy that was looking towards, and regardless of how the delivery went,
Mm-hmm.
looking towards and looking forward to sort of a relief, right?
Mm-hmm.
I want to give her the relief. But anytime you have a procedure, there has to be a relief, and then there has to be the pain of relearning a new thing.
Mm-hmm.
And the only way our babies communicate with us is by crying. And
Mm-hmm.
if a mom's state of mind is not there to be able to see those cues and communication from crying, and if they have this filter of, is my baby in pain?
Right.
They both are going to experience the pain without even knowing it,
Right. And
you
the
know,
stress of that.
and the stress of
And
that.
and so if the baseline, if you have a mom who's already anxious, is exhausted, is stressed, is recovering from what she may, and I hear more and more, consider a traumatic birth, whether or
Yep.
not the medical society or system thinks it's a traumatic birth, if it was traumatic to her, her baseline and her resiliency level is different, and this could just be something that puts her over the top. And I don't know if you
Absolutely.
see this, but what I see typically in those situations where it's done, those are the families that give up easy because they're like,
Hmm.
well, I tried and I just can't do anything
I
else.
tried everything.
I just can't do anything else. This is all I can do.
Yep. And I find that if we don't pay attention to the family dynamic, mom or parents' health, and we are trying to have this baby do this beautiful function immediately after, those are the parents that sometimes feel so disappointed and
Mm-hmm.
so, lost, that it stays with them. I routinely have 9, 10-month-old babies that have been treated somewhere else.
Mm-hmm.
And now they want me to provide a second opinion because they're having difficulties with transitioning from bottle to table
Mm-hmm.
foods or something. So
Mm-hmm.
they're running into that a little bit. And the conversation that I try to bring them to is, function issues, what are happening right now, and things like that. But they are stuck there. We tried
Right.
it. We
Right.
did this, and it
Right.
didn't work. And my baby's still having problems. And then it takes a little effort to kind of get them out of that. So to me, if we did it at optimal time, proper preparation, things like that ahead of time, not only would we have helped that baby at that point, but also the lingering issues, the parents are better suited. So this is a congenital thing that baby is born with. We always hope that we have taken care of it early on enough or well enough that it doesn't have milestone based kind of presence of issues at different stages because we've done it, so to speak. But realistically, you were born with something and you had to take care of it. Chances are that if that baby, especially if the proper preparation and complete release wasn't done, at that next phase at toddlerhood and as they grow up, it might present itself again. And you may have
Exactly.
to do, it may not be another release, but you may have to do some therapeutic interventions.
Mm-hmm.
But if we would have done it early on, maybe we would have minimized at the back end.
Right, right. Maybe things would have been a little smoother as they went through these milestones. So,
Because we did that.
yeah,
So
yeah.
I can come back to, so mummy factors in optimal timing are definitely important.
Mm-hmm.
Moms that have the goal of exclusively breastfeeding, however, if we are treating the baby sooner than even their milk having come in, before they established good lactation support, did they need to introduce pumping in the mix?
Mm-hmm.
Do they have to work with someone to manage bottle versus breast versus nipple shield versus
Mm-hmm.
other
Yes,
things?
yes.
All of those, I know we say compensatory things, but it's more adaptive things for
Mm-hmm.
parents
Mm-hmm.
that need to make sure that intake is going well.
Right, right. And
Okay,
that there is
figure
milk
out,
supply.
is the milk supply
Right.
there,
So
right?
so another type of situation that I encounter is the parent that thinks that there's they think there's a tongue tie issue because the baby's not gaining, but mom's milk either didn't come in or is lacking, or she's had a rough start, or she had a hemorrhage, or all the risk factors for low milk supply. So if we release the tongue tie at that point and there's no milk, the baby's not going to learn to breastfeed efficiently. There's no way.
Exactly.
So
Exactly.
handling all that, and that it's really challenging. And tell me if I'm guessing that you have the same challenge of
Uh-huh.
trying to have parents understand that there's no way to get this done quickly and have the result that you ultimately want. Because the ultimate result isn't release of the frenum. The ultimate result is functional feeding,
Improving function.
right? So
Yep.
it's very difficult. And that's part of the reason why I do this podcast,
Yeah.
because I want to get the word out about how, yeah, we all want it to be easy. We all wish, and
Yeah.
sometimes it is.
Are you a solopreneur or small business owner? If so, I want to ask you a question. Do you know exactly how much money you made in your business last month? Or can you find this number right now with just a couple of clicks on your computer? I'm Sarah Finns, finance coach and accountant and creator of Easy Business Bookkeeping, a course and system for tracking your business finances with ease. I want to bust the myth that managing the money in your business needs to be time-consuming and stressful, or that you need to be a finance professional in order to understand them. With Easy Business Bookkeeping, you will get the tools and support you need to finally gain clarity with your finances so you can grow your business and your impact. Want to learn more? Go to www.sarahfins.com/TTE podcast for details. That's sarahfins.com/TTE, like tongue tie experts, podcast. And I'll see you on the inside.
So I just think that having providers like you come on and discuss that, even though you have the part that's the quick part, you're not in a hurry to do that quick part in this treatment plan because you want
Yes.
to make sure. And what are the kinds of things that like, what do you suggest parents do if they suspect they have a tongue tie? Like, take me through the
So
process
that's
for your practice.
great question. So sometimes I'll have parents that, I've taken care of some of their kids, or I already have a relationship with, and they'll be like, I know my next one, they're pregnant, right? They haven't
Mm-hmm.
even delivered yet.
Mm-hmm.
I know this one's going to have a tie. And my first answer to them is, your first phone call should be your lactation consultant.
Beautiful. Right.
So the lactation consultant will make sure to help you with your health, your ability to help the baby. And then they will also give you some adaptive mechanisms to keep that intake going until I see you. And in
Mm-hmm.
our office, we actually see babies at 2 weeks.
Mm-hmm.
After they've done their 2 week pediatrician appointment,
Mm-hmm.
I find that that is a really good timing,
Mm-hmm.
because they don't have an impending appointment with the pediatrician, especially with all the viruses and everything going around.
Mm-hmm.
I tell parents, don't have a scheduled visit with a pediatrician for a well child and go in a petri dish
Right.
after
Right.
having
Yeah.
had a procedure done.
Yeah.
So I feel like in my office, I find between 2 and 6 weeks is the best time to do
Mm-hmm.
it. It gives parents a chance to work towards having the right
Mm-hmm.
support system. If a lactation consultant does a good evaluation and
Mm-hmm.
notices there is a side preference, muscle tension, something else going on, it gives them enough time to get that bodywork piece in there as well. Some babies, I require that they see somebody for bodywork. Some babies, I say it's recommended,
Right.
but it's a wellness
Right.
thing. Nobody's going to say no to bodywork.
Right.
I don't want to make that a part of a requirement before we do a procedure, but here are some resources. So I feel like the first 2 weeks are
Mm-hmm.
crucial for that.
I agree so much, and I am so respectful of that point of view. I wish that it was more common. There's a lot of people that think that this should be something done in the hospital, and I do not. I almost never think that's the right idea.
Let's talk about that. So in the hospital, and I meant to bring that up, so I'm glad that you did. I have taught at enough hospital locations, and in the attendance, I have pediatricians, hospitalists, SLPs,
Mm-hmm.
ENTs, lactation. I think I got all of them in the attendance, right? Oh, and neonatologists. That's actually neonatologists,
Mm-hmm.
and many times ENTs at the hospital are the ones that are charged with taking care of it at the hospital, right? One of the biggest differences about addressing it in a hospital
Mm-hmm.
versus in an outpatient setting is the perspective of what is outcomes. Okay. In a hospital, especially around birth, people
Right.
forget
Right.
that everybody's thought process is revolving around, is this baby healthy enough to be discharged? Okay. So if
I
actually
hear
they're
you.
offering to
Yeah.
do it at the hospital, it
Right.
is because the baby's not meeting
Mm-hmm.
discharge criteria.
Mm-hmm.
Okay. And it's grim thought process, but it is, infant mortality is still a thing. And that's
Mm-hmm.
why the
Yes.
protocols of the hospital system are to
Right.
catch infants that might have difficulty
Right.
thriving. That's why the NICU, that's why the feeding tubes, that's why
Mm-hmm.
all of the systems and protocols are there, is because they're trying to focus on survivability. Okay. If we focus on function and long term outcomes and all of that, that's where the
Mm-hmm.
functional evaluation, proper timing, collaborative care, all of that is a quality of life thought process. We have figured out in the modern science society of how to help this baby
Right.
survive. We just want to make it so that they are able to eat effectively, comfortably, efficiently.
Right. And gain weight. That's all, as long as there's weight gain. If there's weight gain, everything's fine. So it's so similar. My background, I'm a midwife, I'm a CNM, and it reminds me of the hospital system's thought of, it doesn't matter how the baby comes out, as long as the baby comes out and mom and baby are alive, which is terrible. Like, that's really the bottom line, right? So there are places that do a better job. right? And yes, that's a great goal to go by, but that's not the be all and end all, right? We're not talking about what the experience was like. What's the function like? How do they feel afterwards? What did you have to do? What kind of trauma does mom feel? And it's part of the reason why I don't work at the hospital anymore, actually. But the similarities to that birth paradigm and to the feeding paradigm aren't lost on me, so that, like, what do we have to do right now so this baby is okay, so he can go home? And it looks like he can't open his mouth and lift his tongue. So if we snip that frenum and now he can, we did our job, all's good. And almost nobody tells mom, unless they've had an excellent lactation experience in the hospital, that you have to follow up with someone because there are other repercussions for this. And maybe it wasn't functioning yet. And you have to learn how to use that tongue now and all the things, right?
And that's the difference, where I feel like, some of the advocates in our field are like, do it right away, help mom with this. And I feel like I think there's not a right or a wrong thought process. It's just, you have to understand what the thought process philosophically is based on.
Right.
If you cannot initiate a breastfeeding journey, or you have difficulty that the baby is not even able to coordinate a swallow, instead of a tube, NG tube or G tube or whatever you have to go through in thought process,
Right.
look at that tongue.
Right.
Is that tongue even able to function?
Right.
And a splenectomy.
And there have been babies that I have sent right away.
Right.
There have been babies that I'm like, well, this kid can't even open her mouth enough to get on the tip of the nipple. There is no feeding going on. Everything else is taken care of. Yes. And when I was at the hospital, I worked at the hospital for many years. Tongue tie came into my, my perception probably the last 3 or 4 years I was there. And if there were 2 or 3, maybe as many as 5 babies that I actually, and we had a dentist at the hospital that actually did them if need be. And, but that was it, because I was never sure that was actually the problem until everything else gets settled.
Yeah.
Right? We don't really know the function. It's not fair to evaluate that baby's function.
Yeah. The functional impact of it. Many times when I talk to parents, I also say it's the frenum, or the extra tissue that's there, is kind of similar to having webbed fingers. There's extra tissue. It should have been gone. It's not pathological, but it is there. So it's not anatomically optimal, right? Anatomically correct, so to speak. But if you just release that tissue, then all of a sudden you don't expect excellent ability to write cursive without anything else. And that's a very layman or outside the mouth way, but it seems like parents understand that. Like, you have to then evaluate how much. Some kids who have webbed fingers also have issues with palm, gross motor, as well as fine motor. Some babies that have the tip of the tie involved, completely, ankyloglossia, where they say complete ankyloglossia, they're not having feeding troubles because mom's supply is really good, and mom's, they're writing mom's flow, that the feeding impact is not really that evident still, but they get treated right away because it's visible, and they don't get treated fully.
Right. And I've seen cases of, visibly it looked like the worst, I hate to, the worst, it was the worst tongue tie ever. And the baby was fine. And the baby had mobility.
Yeah, but then those babies sometimes, after the tie release, are having a harder time.
Right.
And then you are like, it's because they had figured out a system with what their muscles were able to do. Now we corrected, quote unquote, the anatomy without proper working, right? Proper preparation for the baby and mom.
Right.
So we talked about the maternal side, right? Like optimal timing on maternal preparation, where moms need to be at a good place to be able to help the baby, right? Emotionally, physically, if they have had traumatic journeys. But on the baby side, we have to make sure that the baby is able to tolerate and utilize the newfound freedom. So,
Mm-hmm.
say when we're doing, I also provide virtual consultations where parents are home. They don't have to worry about getting the baby out and
Oh,
come to the
that's lovely.
office and stuff like
Mm-hmm.
that. That became a part of our treatment during COVID.
Mm-hmm.
However, or during the height of COVID, I don't want to say COVID is done yet, but
Mm-hmm.
during the height of COVID, like 2020 timeframe, where we were all trying to minimize 6 feet apart, 15
Right.
minutes or less,
Right.
things like that. We started doing virtual consults to establish optimal timing, collaborative care is what's going on, do all the things that
Mm-hmm.
need to be done ahead of time before you step inside the office.
Uh-huh.
When parents are showing me inside the mouth, if they are not as comfortable even holding the baby, there are plenty of parents that this is the first baby that they've ever
Yes.
picked up, right?
Yes. And they've never
And
seen anybody nurse.
they've never seen anybody nurse.
Right, right.
Their hands are shaking, even
Yeah.
getting close to the child's mouth.
Yes.
They can barely put their fingers inside the baby's mouth. It's going to be hard, right? Like, to be
Mm-hmm.
able to show me is difficult enough. How do I expect them, and what am I expecting their experience is going to be while I'm taking care of their baby,
Mm-hmm.
right? So, getting that baby comfortable with having parents' hands in their mouth, getting parents comfortable going inside their mouth, doing a little playful activity, kind of connecting with that baby in that oral play kind of sense is the
Mm-hmm.
other part of
Mm-hmm.
creating optimal timing and kind of
Yeah.
working towards. So I
Yeah.
sometimes will tell patients, you have a favorite song? Start using that song. You have
That's
a favorite
wonderful.
story you want the baby to hear? You know how there is a concept of like you listen to the things while you're pregnant so that that
Right,
baby is,
right,
it's all for helping our heart. So get
right.
that baby and mom kind of ready that we want to change the environment in their mouth for the better and get them ready for it.
Right,
So
right.
so optimal timing has a lot to do with parental readiness. It has a lot to do with baby readiness. If there are other medical or physical things, meaning, sometimes babies have cardiac concerns, kidney
Mm-hmm.
concerns, there are other medical things that are also to be considered. And or if the baby's position in utero was so compromised, they have a side preference, they have muscle tension, tightness. Think about what that baby's experience is going to be. If their happy place is looking to the right, I'm going to have them see the in the midline while I'm working the whole time with opening their mouth. If
Mm-hmm.
someone's already helped that,
Right,
their experience, it's a more kinder,
right,
gentler, thorougher release,
right,
and their
right.
experience is better, and my visibility, my access, my ability to do a better treatment for them is improved. So
Yeah.
baby health and mommy health is something to
Mm-hmm.
consider in optimal timing.
I love that. And, the way I explain it to parents is, and this is very lay terms, but babies are born all curled up. And if we try to do anything on them or expect too much from them before they uncurl a little bit, we're
Mhm.
not going to get them comfortable. And the body work part of it is something that we have to talk about. And forgive me, those of you who are quote unquote body workers who don't like the term, who are listening.
I
There's a
know. I've heard that.
conversation going on about the term, but to me, it's the only thing that I can, it's someone that works on the function of the body. And I include, depending on who's available, osteopaths, chiropractors, occupational therapists, physical therapists, um, those that, who I consider body workers, for lack of a better term.
In our
Um,
in our field, we in our area, we also have some really good infant massage specialists,
yes.
chiropractors,
Yeah. Yeah.
that are, and geographically, accessibility wise, I try to
Right.
pair up the provider that I can trust, that they have good expertise when working with
Mm-hmm.
babies and in an around oral area. Like, I
Mm-hmm.
think they're providers that may be focused on the overall body and health, but not as
Right.
comfortable working in and around the neck, head,
And
face,
familiar with infant function and
infant
familiar with
function.
tongue tie.
So you are right. I
Yeah.
feel like we use the term body work as equal to the term release provider, but then there are different expertises in
Yeah.
access.
So I was at an international conference, and at the conference they were saying that the term body work, we're US centric in our speech, and the term body work doesn't mean nice things in some countries. So yeah.
Oh no.
Whatever. It's so hard. It's so hard to have the same language in an international field, but we're trying. But so the thing that I think is important and that I have a challenge for families to understand is that connection of why the baby may need some sort of work to feel comfortable in their body. And one of the things that I explain is if you have a stiff neck, you don't feel good, right? You ever wake up with a stiff neck and you can't drive because you can't turn both ways, or you have difficulty looking over your shoulder and it prevents your movement. So if a baby has a functional restriction in the way they move, how can they be expected to breastfeed efficiently, right? Because and those are the babies, especially if they have one-sided preference or tightness more on one side than the other, which is so common. They will nurse better on one side than the other, right? Or the parent will express that there's a preferred side, or a slacker. I hate the term slacker boob, but they blame it on themselves. That that's the side. But typically, it's the baby can't get into a nice functional position on the side that's not doing as well, and then it produces less. So the idea of we can't require it, but we completely recommend it. And I honestly can say that in my own practice, and I've been doing this for a lot of years, the babies that have had their restrictions other than their mouth addressed prior to procedure and worked on afterwards definitely have better success, better results, easier process with the whole release itself, and less reattachment. Right.
So better experience, better recovery, and better outcomes if we time the release in coordination with the rest of the body's restriction, right? Like tension and restriction.
Yeah. As I call it, the team. If the team is working together and communicating, and this is individual, right? I mean, you talked about a parameter of 2 weeks to 6 weeks, but it's not like you have every baby must have blah, 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 blah. It's so individual, right?
It is individual. Have I treated babies before 2 weeks? Absolutely. Have I talked to moms about what usual is and what we are doing for them so that they know that they have a baby that is younger than the bulk of the babies that we treat. So you are going to have to be extra mindful of if there are in that first 2 weeks other things that if your pediatrician is concerned at that 2-week appointment because the baby was fussy, you may have to go for multiple visits because the pediatrician wants to see at that time. So try to time, and I tell them, try to time your pediatrician appointments in between those times where you're feeding or doing the exercises and all that. So, and I think that is important for parents to know that the recommendations of optimal timing are based on each individual case.
Yes. And then one of the topics that we said we would chat about is techniques of treatment and the different types of tools that are released. And I think you're a good person to speak on this. As we were chatting before we came on, most of my own experience is with a certain type of laser. You use a different type of laser. There are people who are very proficient with scissor, but I think more not. But, so let's talk a little bit about that.
Yeah. So I always say we need to focus on the provider, and the provider can focus on what is their best tool. Right? So the qualification of the release provider is what parents know. Do I trust this doctor to take care of my baby? And then they should trust that that doctor is a master of their domain.
Right.
When it comes to which tools to use, I feel like the layman comparison I make is like it's like Harry Potter.
Mm-hmm.
He loves his wand, right?
Mm-hmm.
And sometimes, if you have done enough to master your tool, you may not feel as proficient with a different tool. If there is a provider that uses scissors and they know how to use scissors really well, of course, you will have good outcomes. The problem is there are some limitations of the tool that the provider then has to work around. So, for example, when you have a baby that has an anterior tie, that has a membrane well defined, comes very anteriorly, you are able to separate and you can actually sever from the sides where the scissor can come around and sever and release, right?
Mm-hmm.
If you have a baby that has a submucosal attachment or a more, webby, what we call posterior type of attachment, those are the ones where it becomes a little more difficult to approximate the tissue well enough for use of scissors, right? To approximate to, because scissor comes from the sides and then releases versus lasers release like a pen. They work in a straight line.
Where you point it to, in other
We
words, for those
point
who
the
can't
laser
see.
beam to the area.
And
when it comes to laser beam,
I think that what impresses me with the laser as opposed to scissor, and it goes along with what you're saying, is it's almost like one cell release at a time.
Exactly.
Right. Whereas, like what the difference between taking a bite out of something or peeling something back.
Exactly. Absolutely.
So,
great example. Great difference. Now, when it comes to lasers too, we think of laser and we use the term laser, and we can go back to the term bodywork or the term release provider. There is always differences in each once you start looking at the details of it. So there are many different types of lasers available, especially in America versus around the world. There are many tools and different companies that may have mastered the delivery of that laser beam. Okay. Versus if you look at the electromagnetic spectrum, it's, the UV rays, the visible rays, and the infrared. All the laser beams, all the lasers that are available in the market and FDA approved for biology and biologically friendly tissue, all fall under infrared. Okay. And they use laser energy to build in. They may have different levels of heat that build up because it's energy. There's going to be heat. So then one of the most easily available kind of misrepresented of the laser world, I feel like, are the diodes, because they are more dependent on heat rather than the laser beam energy.
Right.
Okay.
Right.
So there will be some providers that are, have to learn how to manage that heat buildup. Right. Because if the heat builds up in the tissue, then it's almost similar to an electrocautery, which is not necessarily a laser release. It is more of using a, hot knife or a laser, like using something that is using heat to kind of quote unquote burn off the tissue.
Right.
And you don't like to hear that, right? So the provider that's using that has to learn how long the laser beam can be, or the diode laser can be on the tissue. Also, diode laser works with the contact mode, like you have to touch the tissue, versus other lasers work in a non-contact mode.
Yeah.
So in my practice,
releases that looked okay, and I've seen others that were upsetting to me. Yeah. Yes,
and it's the matter of how the provider has mastered that tool, right? Like if they allow for thermal relaxation, have they allowed for, like a wet gauze, moist gauze to kind of take away some of that heat impact
but
of
that's
the
not the
tissue
type
and things
you
like
use,
that. So
correct?
The comfort level comes into play. I don't use that. I don't use that in my office. We use what is called a water laser. And the reason it's called a water laser is because with that laser beam, there is an air water mist that also comes from the handpiece itself. Water is considered the medium of delivery of the laser energy. in my experience and in my studies, as a part of the Academy of Laser Dentistry, when we do all the, the didactic part of laser training, it is very clear that there are certain energy areas that have great compatibility with biological tissue. And so erbium lasers and CO2 lasers are considered pretty similar in that spectrum.
Okay.
So the water laser is an erbium laser, and it works on water and hydroxyapatite tissue. So while diode lasers might be looking for hemoglobin and melanin and things like that, the water laser or the CO2 laser are looking for water content and hydroxyapatite. Okay. The water laser, because we talked about that heat buildup and things like that, water laser is able to have that air water mist. We have a small little suction. We can have the gauze there. It kind of protects the surrounding tissue from that heat buildup.
Okay. So it cools things down as it's doing it instead of letting the heat stay
Exactly.
there.
And so we are able to use the laser from a distance that is a few millimeters away and build up the laser energy to desensitize, demarcate, and then release the tissue. So if you think about all that, it's a little slower than the scissors, right? However, it's actually preparing that tissue to be gently released, and then the tongue is able to work, or the lip is able to work much more effectively. We don't have to worry about local anesthetic, and we don't have to worry about the buildup of, we have to dose it for babies and things like that. So we don't have to worry about all that. But it also does coagulation. We don't have that luxury with scissors or scalpel.
So coagulation for lay people listening means clotting so that there's not too much bleeding. And so,
Right.
you know what, I want to bring this back and think of, to address the people who may not be as familiar with all that goes into this and are trying to choose a provider for their own experience. And as I hear you explaining the technicalities and recognize the value of all the education and training that has gone into this, I think that that's the most important, the more important questions to be asking providers. How long have you been doing this? What kind of training do you have on the laser you do? How many times have you used it? Right?
Yep.
Is this something
Yep.
you do if you need to? You pull out your thing out of the closet, or is this your practice that you've dedicated your life to? Because when we use the term preferred provider, which is the internet term, I think that's a misnomer. What we should be saying is the dedicated provider, the experienced provider. Sometimes they're the same, not always though, right? So someone like you, I would consider a dedicated provider that if you were in my local area, hearing what you're saying and your expertise and the value that you're bringing to the families that come to your practice and the level of understanding you have of the tool you're using is impressive. So thank you for doing that, and thank you for being that to the families that you take care of.
You have to realize that many of us providers have not learned about laser or even infant oral health as a part of our basic education.
Right.
That tide is turning, and my generation of providers are sort of the ones that are now hoping that we are training the new residents so that the graduating residents don't say the same thing in 20 years, right? So people that have gone through the education, gone through the experience, are the ones that are going to be able to help with optimal timing versus, everybody's in their starting of their journey. All providers start somewhere, but they have to know that I'm starting versus this is my experience, and be able to articulate that to the parents, right?
Exactly. Yeah. So I think we've covered as much as we're going to have time for today. I totally enjoyed this conversation, and I am confident that my audience will enjoy it and learn from it as well. On a personal note, it was great to see you again, and I hope I get to see you and chat with you soon. before we sign off, is there anything else? Is there anything that you feel like you want to add, or anything that, you want our listeners to hear?
I think my only thing that I want people to take away from our conversation today is the importance of team approach, importance of maternal mental health, importance of a prepared baby and mommy. And then if you've done those things, you would have good guidance to find the right provider for the type of problem that you're having and find a good timing to address it in the best outcomes can be achieved, right? So that's the only thing I would say. Don't lose sight of the process because you are so expecting that procedure to be the answer.
Right. I love that. Thank you so much. Thank you so much for giving us your time today. And I hope to talk to you soon.
Thank you. I appreciate it. Bye-bye.
Thank you so much for listening to this week's episode of the Tongue Tie Experts podcast. Check out the show notes for useful links about the topics we discussed and for ways to follow us on social media. Please subscribe to us on your favorite podcast app. And if you enjoyed listening, we'd love it if you'd rate, review, and share with your friends and colleagues. Thanks so much. Bye-bye. Tongue-tie cases can be confusing, but what if you had a place to ask questions, learn from experts, and connect with professionals who truly understand? That's exactly what you'll get when you join Tongue Tie Experts Insiders. It includes monthly online meetups with me, Lisa Paladino, expert guest speakers sharing the latest research and best practices, a private community of other professionals ready to support you every step of the way. For just $19.99 a month, you'll never have to navigate tongue-tie cases alone again. Join the community today. Your future self and your patients will thank you. Sign up now at tonguetieexperts.net/insiders.